Good evening, ladies and gentlemen, and welcome to this webinar that is being jointly hosted by the National Council of Applied Economic Research in New Delhi, Yale University in New Haven, Stanford Medicine in Stanford, and IPA in Bangladesh. We are delighted to have you with us on a topic that is of grave importance for South Asia and certainly for India. I don't need to belabor the point about the crisis that our country is in and our neighboring countries as well. And while governments strive hard to provide the medical infrastructure and the facilities that are needed and ramp up the production of vaccines and the distribution of vaccines, we also need to be looking at other ways in which we can help halt India's second COVID-19 surge. We're going to look at lessons from a large-scale masking experiment in Bangladesh. And the reason why, of course, masking is important is because, as the scientific evidence shows, and I'll introduce our panelists who will be talking to this, aerosol transmission of very small microscopic particles is possibly primarily the way in which this virus is transmitted. Masking represents also a soft approach to lockdowns, where we are able to do things, pursue economic activities that otherwise would not be possible with the kind of lockdowns that many countries around the world have had to enforce. So there's a lot to be learned here, there's a lot to be understood and a lot to be thought about in terms of how community masking, not just an individual, but entire villages, entire communities coming together to cooperate and mask is what we are going to listen to today. I'm delighted to have with us a range of specialists in this area. The key speaker is going to be Professor Mushfiq Mobarak, Professor of Economics at Yale University, with concurrent appointments in the School of Management and the Department of Economics. He is the primary leader of the work in Bangladesh and has a range of other affiliations and associations that are there in his profile that you can download or look at. With me is my colleague, Dr. K.P. Krishnan, faculty member at NCAER. He holds the IPF chair in regulatory economics, but until recently, he was also the union secretary to the government of India in the skill development and entrepreneurship ministry. Prior to that, many positions in the Ministry of Finance, somebody who has tremendous experience in terms of government and in terms of administration. I also have panelists who are going to be commenting on the issues that Mushfiq Mobarak will be talking about. First and foremost, Gagandeep Kang, professor at CMC, Christian Medical College, Vellore, one of India's premier epidemiologists, a fellow of the Royal Society in the UK. We are delighted that Gagandeep has been able to devote time to this webinar. I also have Mr. D.K. Tiwari, who is the Principal Secretary in charge of the Medical Education and Research Portfolio in Punjab. I'm sorry that Chief Secretary Vinny Mahajan, who was supposed to join us, has been called into a cabinet meeting, and we are very grateful to Mr. Tiwari for joining us. Thank you, Mr. Tiwari. I also have with us from Karnataka, P.S. Harsha, who is Commissioner in the Department of Information and Public Relations, who is joining us from Bengaluru. Again, Mr. Javed Akhtar, Additional Chief Secretary in charge of Health and Human Welfare, is unable to join us again because of a cabinet meeting. So I'm very grateful to you, Mr. Harsha, for joining us. So without further ado, I'm going to request K.P. Krishnan to just give me a sense of the framing of the issues from his perspective. And from his obviously tremendous administrative experience. This has to be a private-public partnership, And so it's really important for us to think about that in the context of India. So over to you, Dr. Krishnan.
Thank you, Shekhar. Very good evening to all of you. Excuse me. At this very sort of sobering time of exploding COVID-19 cases, let me take the opportunity to invite you all to join us in discussing something which can truly help in handling this very surge from getting worse. In the NCAER, we have been in our own humble sort of academic and research way trying to contribute to this large sort of issue. In August of 2020, in the India Economic Policy Forum, we had a full panel discussion on what at that time seemed like a slightly distant likelihood, namely vaccinations. And we had the Union Health Secretary, besides the Secretary Biotechnology of Government of India, who joined us, and a very good sound paper presented by Dr. Ajay Shah. Some of the suggestions in that paper and that discussions have eventually got going in the round of changes that were announced recently. And thereafter, in end December, we had a more sort of extensive, very detailed discussion led by the then chairperson of the National Health Authority, Dr. Indu Bhushan, on vaccinating 1 billion Indians, where again we had very, very sort of capable, serious people involved in policy as well as researchers suggesting ways forward for the upcoming challenge of vaccinating 1 billion Indians. Ironically, the most cost-effective method perhaps of dealing with the virus and the least adopted appears to be the solution that we are going to be discussing today. Solution in a sense of a pre-problem solution. Clearly, it's not a solution post-COVID, but like a lot of public policy, half the effort of governments actually should be spent on avoiding getting into trouble. Because once we get into these troubles, these are not handleable in as easy a manner as the preventive activities. So the irony comes from the fact that even today, there is evidence of very low mask use in a lot of India. Anecdotally, we see it even today when we walk out in our respective colonies. But I think on a more serious, sort of less anecdotal, more rigorous note, we look forward to what Professor Mushfiq Mobarak is going to tell us on this very large randomized controlled trial that he and his team have carried out in Bangladesh, and as one would suspect, reached very startling but actually very quote-unquote simple conclusions. Our difficulty, and I think this is where we will look to Mr. Tiwari and Harsha, one directly dealing with health and the other, appropriately enough, dealing with communication on how does one communicate to a large audience what appears to be a simple message, a message which actually costs very little, has low consequences, in fact, zero consequence other than positive consequences for the adopter, but still does not get done. So it is in this context that I join Shekhar in welcoming Professor Mushfiq, Madam Gagandeep. We are privileged to be able to read a lot of the writings of both of you, sir and ma'am, and we've benefited enormously from your very sobering, practical, and yet candid writings on the subject. We also look forward to Mr. Tiwari and my own colleague from Karnataka, Mr. Harsha, in explaining to us the cause, but more importantly, how does one handle this going forward? With this, it's my privilege to hand you all back to Shekhar for taking forward the proceedings, and look forward to meaningful, productive, and useful discussions which will help us handle these difficult times. Thank you, and namaskar once again.
Thank you, Dr. Krishnan. I'll hand it over straight to Mushfiq. Mushfiq, and just we'll coordinate between your slides and the poll.
Thank you very much, first of all, for organizing, Shekhar and Dr. Krishnan. This is, so first of all, before I start speaking, it is a sobering time. First and foremost, I hope everybody who's here that you are healthy and safe and your loved ones are as well. We've had lots and lots of lows over the past year, but what's happening right now is still astounding. And so it's a very timely discussion, and I would actually like to move beyond research very quickly. Of course, I do need to talk about what it is that the evidence tells us, but if all goes well today, I hope that we'll have lots of discussions about action and implementation. And so the panel that you've put together, bringing together a researcher along with people with the capacity to take large-scale action in government. Thank you, Mr. Tiwari, Mr. Harsha, for joining us. And thank you, Gagandeep, as well. So that's I think that's where we need to move to very quickly. So hopefully we'll be able to talk about the details of implementation. So with that, let me start by telling you what the results are about. So this work was done in Bangladesh, and it was done with a large number of partners, some representing a much larger group here that I'll explain. And we're now thinking about what the implications are for implementation across South Asia and what types of issues arise when we think about scaling up. So of course, we do need to think about large actors like government or large NGOs with the capacity for scaling. So I'm going to spend some time talking about what is necessary there. So I am representing a very large team. I just happen to be the speaker, but the team that conducted the research I'm about to tell you about has many different types of expertise, right? So for one thing, we do at Yale, we are leading sort of the economics and the behavior change aspect of this project, which is important. But Stanford Medical School, a large lab and a team of people, some of whom are in the audience right now, are leading the public health and epidemiology side, and it turns out that we also need engineering expertise because there's important questions about mass design, proper materials, right, as well as logistics and mass procurement. So Innovations for Poverty Action, which is sort of JPAL, which is well known in India, it's a sister organization. They, it's an international NGO with we have a lot of presence in Bangladesh. So they've been a key partner. Both non-government and government actors in Bangladesh have been key partners. And we're also happy that in our policy outreach in India, we are now taking advantage of the existing networks that JPAL has built up. So they're going to be a key player in anything we do going forward in India. And all of this work was funded by GiveWell. Okay. So why do we want to think about masks? So there is already, and why more research? There's a lot of scientific evidence already about the usefulness of face masks to prevent COVID-19 transmission, to slow the spread, right? And as you see with what's happening in India, that a lot of what's happening right now is a lot of excess unnecessary death. So this harks all the way back to April, March 2020, when we were talking about flattening the curve and extending the period of infection as to when large numbers of people get infected so that we don't overwhelm the healthcare capacity, right? And masks are really helpful for that, which is that you don't want to get into a situation where the number of people getting sick on the same day exceeds the capacity you have for hospital beds, for oxygen, et cetera, et cetera. So there's already a lot of evidence that masks are helpful. However, right, what we need more evidence on, that we try to provide here is not only laboratory studies as to whether masks are effective at preventing virus particles from getting through, for which we have lots of strong evidence, but is this something that can be done at scale at the community level, because it turns out you wear masks not only to protect yourself, but to protect each other. So we do need community-wide mask wearing norms to change for us to really be protected. And that's our goal today. Okay? And there are many different strategies to get at this at the community level. And what we end up doing today, as I'll show you, that we try out many different things, like taking insights from psychology, from marketing, from economics, from say other campaigns like like India's Swachh Bharat campaign, and prior to that, the Total Sanitation campaign. Right? We try to take insights from all of these different angles and then do a very large trial where we throw 20 different things at it and see what works. Right? So I'll talk about those results. And another reason to do this research, and this is the primary reason that the WHO kind of equivocated about masks and how strongly that they would be promoting masks for the last year. And that is the concern that, oh, you know what, we don't have like this kind of a strong randomized controlled trial-based evidence that masks can work at the community level. And if it gives people a false sense of security, then they might stop doing the other things that we recommend, like social distancing, et cetera, right? So story of kind of like a moral hazard, that you feel like you're protected, so then you go party, right? And so we are going to also test carefully whether or not mask usage actually leads to such compensatory behaviors, right? And then finally, I think, hopefully vaccines will be the end game and it'll arrive soon for us, right? But many low-income countries, including the ones in South Asia, right, as well as other countries that have even less access to vaccines, I think vaccines as a solution is a year or more away. And so until then, it's important for us to think carefully through how can we flatten curves, how can we protect public health until we have the chance to get people vaccinated. So this research, as I said, it has both the epidemiology, public health aspect, as well as sort of economics and behavior aspects. So it comes in two stages. So the first stage that we'll focus on today is the one in green, which is what types of strategies can we use to increase mask wearing. Okay. And then once you have been able to, through a trial and these economic strategies, you have been able to get people to wear masks, then you can ask the question, okay, what is the impact of this mask wearing at the community level on COVID transmission, right? So for this, we have already collected, after doing the trial that I'll describe, we have collected blood specimens from tens of thousands of households across Bangladesh to check for seroprevalence, whether or not there's COVID antibodies in the treatment areas versus the control. Now, we won't talk about this today at all. I think that right now, our focus is on just taking action. Now, what do we need to do in order to get people to wear masks? So I'm going to focus much more on the behavior as opposed to the epidemiology for today, right? And all of the results that I'm going to tell you about today, I won't get into the research methodology details because I feel like this is not the right forum and time for it. But I just want to let you know that this is a very large scale randomized control trial done at the clustered at the community level. It involved almost 350,000 adults across 600 villages in Bangladesh. So it's an unusually large trial. And we needed to do this large trial because, answering this question requires large sample size, right? So that implies two things for us. So one is that everything I'm about to tell you, I can say with a lot of confidence and statistical precision, right? And the second thing is that because we have such a large size of a sample size, that allows us to try out these 20 different things, because then I have enough sample for any one particular intervention out of the 20. And that's why I'll tell you a lot about what works as well as what doesn't work. Okay, so bottom line, a cluster randomized trial, 350,000 households. We'll talk a lot about mask design as well. We've tested in some areas cloth masks, other surgical, because the government of Bangladesh has been unsure about this particular choice. We tested a large portfolio of encouragement strategies, and then we're studying the effect on infection rates. Okay, so now before showing you the result, I'd like us to run a couple of quick polls just to see your views on what you think might happen under different types of interventions. Right? It's useful for us to also to get a sense of which of these things are obvious, what's surprising, because as we are now speaking to government officials across different states in India, it's useful for us to know to tailor a policy outreach. So can we run the poll? So this first question is that we start by providing free masks to all households, so door-to-door distribution, and promoted mask wearing in markets and mosques. We engage community leaders and imams in Bangladesh, who are important community leaders in rural areas of Bangladesh, right? And in our control villages where we didn't do any of these things, 13% of people were wearing masks properly, covering nose and mouth. And so I'm asking you to take a guess, right? How much did that increase by when you do these, you do basically free mass distribution plus engaging community leaders? So that's question number one. And then question number two is asking, with the same set of answer choices, right? Imagine that you do all of this that I just described, plus you go and do some follow-up monitoring and stopping passersby, like intercepting them if they're not wearing a mask, and asking them to, put the mask on, right? That we had distributed. So the second question is, how much does that increase masking by when you add that component?
We'll give it a little bit of time just so as to let people think about the question. I just want to repeat what Mushfiq said, that the base is the 13%, that the villages that did not have this kind of involvement of the team. And so question is about how much higher in percentage points beyond the 13. I'll give it another 20 seconds and then we'll stop. I'm going to stop the polling now and then show the results right away. Should I, Mushfiq?
Yes, please.
Okay. So these are the results that we got.
Okay, quite a lot of variation across everybody in the audience, but it seems like increased by 20 percentage points wins for the first, and then increased by 10 percentage point wins for the second one. Okay.
I'm going to stop sharing these results. I want to reassure everybody that, of course, everything is anonymous here, so we're not tracking who's saying what, so you can speak freely or make your choice freely. I'll move on and then we'll come back to some of this later on. Okay. There we go.
So let me maybe just start with the bottom line, just to give you a pictorial of exactly the combination that was necessary to get larger increases in mask usage in Bangladesh. Okay. So what we had to do was to work at 3 different locations to sort of capture the entire catchment of the community, which is working at homes, so door-to-door free distribution of masks. That's number 1, right? Number 2 is to do some secondary distribution at the mosques, especially on Fridays when people gather for prayers, because that's a particularly dangerous time where everybody's coming together and standing shoulder to shoulder. Okay? And then a third place where people gather at sort of high density was at markets, and that's where we also work. So those were the 3 locations that were important. When we did the free distribution door to door, we also had prepared some information materials. So there was a video that the Prime Minister of the country, the Shakib Al Hassan, the best cricketer we've produced, and the director of the Imam Training Academy, we got them to record little snippets. We made a video out of that to sort of highlight the importance of mask wearing and protecting each other. And we also had brochures and things like that we left with households of nothing for. So there was like distribution plus information, right? And then here's what the poll question was about, which is including or excluding this last piece, which is, do you need to go back to the communities and intercept people if they're not wearing a mask and tell them, oh, we distributed masks here, why don't you have it on? Can you please put it on, right? And if if we, if they say, oh no, I left it at home, we ask them to go back and get it. If that's inconvenient, we actually had replacement masks that we handed to folks. Okay, so this turned out to be a necessary component, in that if you do all of this free door-to-door distribution, right, plus the engaging community leaders, plus going out to markets with megaphones, putting posters up, et cetera, if you do all of this, we actually get a pretty small increase in proper mask usage, only about 10 percentage points, which was the answer to the first poll question, right? When you add this, right, that is what more than triples mask usage. So from 13, it goes to about 43. Okay? So this turned out to be like, you cannot just distribute masks. I mean, the distributing masks is important, but you cannot just distribute and leave it without doing this type of a follow-up activity where you remind people that it's important for you to wear the masks and that somebody's here to like monitor this. Okay, so now that this worked well, this increased mass by 30 percentage points, right? Let me add one more poll question. Okay, so once we saw that this worked well, then we added to this activity the village chowkidars, like the village police, to accompany these mass promoters. Okay, so that way, the idea was, oh, maybe people will take it more seriously since this is an important component. So do you think? So what do you think it did to mask usage? So simple yes/no question. So did this increase mask wearing further? We can probably just leave it open for 20 seconds. Yeah. So 60% of people say yes, this would have increased mask wearing further. Now here's the surprise. Once we added the chowkidars, that didn't change anything at all. Okay? So it's important for us to also identify what doesn't work, because it turns out the coordination with the village institution, the police, etc. Of course, that's time consuming, it's costly, right? Difficult to do at scale. And it turns out it doesn't do much for us, right? And why does it not do much for us? Our interpretation is that this awkwardness of a conversation, of somebody stopping you and saying, why don't you put on your mask, right? That seems to be sufficient. That's what people worry about, like the little bit of informal social shaming that's happening, whereas they're not really worried about any threat of legal sanctions, right? In fact, during much of this period in Bangladesh, this went back and forth, but the government, was trying to have sort of a mask wearing requirement on the books, right? But of course, enforcement is, as you can imagine, especially in rural areas of Bangladesh, would be highly uneven. Right? So this turned out to be a surprise for us, that this didn't do anything more for us. But that's something that's useful to know, because we want to do the things that are most cost effective. Okay, so now let me just go through and show you the results quickly. So number one was that free mass distribution, promotion, the in-person reinforcement, that package that I just described in that picture with these 4 things, right? That more than tripled mask usage, and did so in all locations. So we had surveillance staff, like not separate from the mass promotion staff, so not wearing any identifiable clothing. So they were just sort of standing in street corners and various locations to see, oh, what's happening? Are people coming in, walking around with masks? And what you find is, and they were also trained to look for proper mask wearing, because it's important that the nose and the mouth be covered, and not that you're just using the mask to hang it on your chin. Okay? And so what you find is across all locations, it more than tripled mask usage. That's true overall. At markets, there was a very large increase at mosques. And this was important, right? It goes from 12% in the control villages to half the people at mosques wearing these masks, right? And this is important because this is one of the most dangerous times when people are standing shoulder to shoulder. That's number one. Second, the effect that I'm talking about, very importantly, it was sustained as with the entire time that we tracked and did the surveillance, right? It was sustained over 10 weeks. So this is not just a novelty factor where people just do it for 1 or 2 days, right? We kept tracking it week after week, up to 10 weeks. And you see that in the treatment area, the proper mask usage stayed above the control area throughout. And importantly, part of this period is after we left the village altogether. So it's not that we had to keep watching and keep reminding people, right? Once there seemed to have been some changes in social norms, where once a norm changes, that it continues without us having to do the watching. And when social norms change, the nice thing is that then people watch each other, and government doesn't have to come and do it, right? And that's the same kind of idea that we have, say, in addressing open defecation in India and across South Asia, right? You need to have social norms change. You need to have move from a situation where it's normal for me to openly defecate to a situation where it's socially looked down upon, right, for me to openly defecate. So I'd say introspecting, a year ago, if I wore a mask in the US, people would look at me funny, right? And I also would wonder, why is that person wearing a mask? What's going on? Whereas right now, if I don't wear a mask, people look at me funny saying, why are you being, or thinking, why are you being so irresponsible, right? So it's kind of shameful for me to go out without a mask on. Okay, and this is the next question. So did the free mass distribution and promotion change social distancing behavior? And let me poll you again on what you think happened here. Did it increase or decrease social distancing, or was it unchanged? Oh, sorry, the poll isn't ideal here because there should be 3 options, right? Decreased, increased, or unchanged. But we'll see what you got, what you all think. And I think we can move on. So it turns out we were positively surprised here that once you do the mass distribution, not only is it the case that social physical distancing did not go down, it actually increased, right? So the worry that the WHO had, right, which is a legitimate worry that, people are not going to social distance anymore if they think that masks are protecting them, right? That's not at all true. What you see is overall, there was a 5 percentage point increase in social distancing, in markets even larger, right? Now, mosques, absolutely nothing happens. Nobody social distances because people stand shoulder to shoulder, right? But in all these other locations, you actually end up having this ancillary benefit of protecting the community. And what do we think is going on here? Once you start talking about mass promotion and providing this information, and people see, okay, we're all taking it very, very seriously, they actually take everything seriously, not just the mask wearing, but other forms of behavior as well. Okay? And then one thing we've already talked through, that this in-person reinforcement was an essential complement, in that when we did the first 3 things, the free distribution, the mass market work with the imams, etc., we saw relatively small increases, a 10 percentage point increase, right? Whereas once we added the interception, right, that's when it went up even more. Okay.
Mushfiq, just go back to the last slide. The third column, how is that different from the second column?
So this was just the second pilot we did at the pilot scale when we added the reinforcement, and this is the full intervention, right? Like done at scale.
Okay.
So we just, we kind of so there was a little bit of iterative experimentation going on in this project where we were trying things out, adding things, right? And then collecting more data. So, okay. So we've already started talking to various state level government officials across India and some province level officials across Pakistan. And one of the issues that comes up, people are really curious about, is about the mass type. What types of mass should we be promoting? And here, we went into the project with true equipoise, right? Where the government of Bangladesh and other local experts, when we discussed with them, before actually launching the study, their strong prior was that no, surgical mask is not going to work. This is not a solution. Okay, why? Because people associate that with a low quality, one-time use product. Okay. Now here's one detail that came from the field, the types of kind of lessons that you can only get from the field that is really difficult for us to otherwise intuit, right? So it is true that people had that sort of a attitude towards surgical masks. They're a low quality product, right? But we addressed it in the following ways. So one is that it turns out these surgical masks can be washed and reused. Okay, they're not one-time use. Okay, so how do we figure that out? So we first test we take masks produced, and we took a lot of masks produced in India by Magnum, by various garment factories in Bangladesh and other manufacturers, right? We put them all in a FedEx box, shipped them to a lab at Stanford, and did the filtration efficiency test. And we learned that these surgical masks, when they're made well with 3 layers, right, they start out at like 95% efficiency, whereas cloth masks, even made to our specifications, where we had to be careful about, okay, what material is available locally, right? And can we do the proper design, which came from an engineering lab at Stanford. So once we do that, those cloth masks, the best type of cloth masks, start out at 37% filtration efficiency, okay? And here's the next interesting thing. So we take these surgical masks, right? We wash them, test them again, wash them, test them again. And we did this both at Stanford as well as the Tata Institute of Fundamental Research in India. And what you learn is even after 10 washes, hand washes with soap and water, the surgical mask retains 76% filtration efficiency, right? Better than where a new cloth mask starts at. Okay, so that's one reason why we are a fan of the surgical mask. A second reason, of course, is that it's much cheaper. Right. So now that we have negotiated prices, we know that you can get surgical masks down to 6 cents, so something around 7 rupees per unit, and they can be produced extremely fast. They don't have to be individually stitched. It's a machine thing. So if a government is trying to procure at large scale, it's possible to do it very quickly. And then one other thing we learned is that in order to signal to people that this can be washed and reused, to get over their initial hesitation about this, we put in a sticker, right, that says you can wash this mask and you can reuse it in Bangla. Okay? And so that seemed to have helped to distinguish our high quality masks. And then when people had this concern in the field, what we learn is, we show that, with our triple layer mask, like, look, hold it up to the sunlight, light doesn't get through. But look at your low quality, surgical mask that you can buy on the street side. It just looks very different when you hold it up to the sunlight, right? And people found that convincing. And then over time, in the hot and humid weather of South Asia, right, we learned that in general, people start disliking cloth masks, so they start disadopting a little bit more, right? Whereas the surgical mask, they actually retain their adoption and use much better over time, because people over time, like, when the cloth masks lose their smoothness after washing, they don't like it as much. Okay, so these are the various reasons why we are proponents, but I should be careful to point out some mask is better than no mask. So when we are doing the scale-up work now across various states in India, sometimes we learn in a particular organization, but we actually have lots of cloth masks available because this is a livelihood strategy for the women, our women members, say at Seva. And my reaction to that is, okay, if you have it available, let's just start with that, because what's most important for us is to get people to wear a mask, right? Not to let the perfect be the enemy of the good. Okay. All right. Is this a good investment? So I want to now talk about implementation for the last maybe 5 minutes, and I'll stop. Okay. So we've tried to collect information on costs in a variety of ways. So first of all, we measured the cost of applying our treatments very, very carefully, right? And per village, so imagine an average size village in Bangladesh has 200 households. It costs the equivalent of 1 to 1.5 lakh Indian rupees to run this for 2 months. Okay, or maybe that was a monthly cost. Okay. Now, one thing I want to quickly point out is that, and so this is the cost of everything: hiring the staff, doing the mass procurement, like every single thing that I talked about, like hiring staff to go in and talk to the imams and other community leaders, get their endorsement, right? And something a detail I didn't tell you, when we do the endorsement of leaders, right? Like when we go to the mosques, we do have to in advance talk to the imam, get him signed on, right? And have him read a pre-prepared script to the congregants, right? And I think in India, across various places in India and Pakistan, we would want to do the equivalent with other trusted local leaders, like whatever the local institution that happens to be important. So all of those costs together is this, right? And this gives us, now that we know how much mask wearing went up by, how much transmission went down by, we can compute like what is the cost per life saved, right? And expectation, it's about 20 to 50 lakh, which is actually a very a very reasonable and very cost-effective way to save a life relative to many other things we do in the world, right? But maybe for policy, the most important thing to think about are the comparisons between sort of this mass promotion versus the key alternative policy that the government has at its disposal, which is a lockdown, right? So given our data on how much transmission went down by in the areas where we did mass promotion, we think that this mass promotion strategy that I just talked you through, right, that is equivalent to about a quarter of a lockdown. That's how much it reduces transmission by. Lockdowns are better. It reduces transmission 4 times as much, right? However, the important thing is that lockdowns are a lot more expensive because we now have data, good data from the last year on what the GDP losses are, right, associated with lockdowns. So if the mass promotion allows you to get away with a slightly less stringent lockdown so that it's not so aggressive and not so threatening to people's livelihood, especially among the poor rural folks, or poor urban folks for that matter, then you can actually end up coming out ahead and saving a lot. So we estimate that per village, you end up saving about 90,000 rupees, Indian rupees per village per month, right? And for an average sized district in India, the cost saving, the rest can be estimated to be about like 19 crore per month. Okay, so this is sort of replacing a more stringent lockdown with a less stringent lockdown along with the mass promotion. And the key point here is that the mass promotion just happens to be a lot cheaper, right? And all of these costs that I've computed for our mass promotion is the cost that was to us, which was actually expensive because you're trying to run a trial, right? Where you have to carefully separate the treatment group from the control group, etc., right? Whereas we've now gone through the cost estimates, worked with our implementing partners, right? As to how much this would cost at scale when we do bulk orders, when we use mass media instead of individualized information, right? Individualized information is more important because you can't use mass media because you want to keep the control group separate, right? Now at scale implementation, you don't have to worry about that. And after going through that exercise, we think that cost can easily be brought down another 60%, right? So it's already a good deal. It can be a much, much better deal. Okay, so let me ask, now I want to just give you a quick short analysis of what else we tried. I said we tried 20 things, right? What helped, what didn't help. So if you could just launch the last poll, just a series of quick yes/no questions, right? So one question is, we experimented with this. We sent people text message reminders, right? Did that increase mass swearing? I'm not asking you to guess numbers, just yes or no, right? Then we tried something that psychologists, the psychology literature tells us it's important, which is ask households to make a verbal commitment, right? That I'm going to wear a mask, because psychologists tell us that once they make the commitment, they're much more likely to follow through, right? Did that increase mask wearing, right? And also we tried something else, which is display to others by putting up a sticker, yes, I'm a mask wearing household. Okay, so that's the next question. The third question is, we promised the village and the leaders an incentive payment. In our case, we promised equivalent of $190, right? If we saw increases in mass wearing in the village, do you think that this increased mass wearing? Providing incentives. Okay, mixture. Many people think that these are, like majority think that these are useful. Here's the thing, we learned that none of these were cost-effective strategies, right? So as we already saw, the threat of legal sanctions didn't do much. That seemed to be unnecessary, right? This putting signage on a door saying that you're a mask-wearing household, that had no additional effect. This is not harmful. Like none of this is harmful. It doesn't reduce the effect, but it doesn't produce anything extra for you. So you can safely avoid it. Right? Having people make verbal commitment, nope. Sending text message reminders, in this particular case, no effect, right? Promise of monetary incentives, no. And also we tried social rewards instead of a monetary incentive. So like a certificate issued by the government, sort of modeled after this idea of, this is an open defecation free village, right? None of these seem to have any effect. So these kind of behavioral nudges don't seem to be where the action is. So and this is not to say, like, that's true for this countrywide study in Bangladesh. This is not to say that these are going to be definitely useless in other places. Now, if a state government in India already has it's very cheap for you to send text message reminders because you already have the database of numbers set up, right? I would say, sure, go ahead and do it. Why not, right? But if this is something that's costly and time consuming for you to put together, let's not worry about it. Okay, so what is needed and I'm pretty much done now, is the door-to-door distribution plus a follow-up reinforcement. That's critical, right? Just the informal social sanction was sufficient, just like stopping people having this slightly awkward conversation that gets them to change behavior. We learned that surgical masks do well. They hold up better, right? It was very important for us to do local leader engagement because we saw that we have some heterogeneity across villages. In villages where the local leaders, informal community leaders were very engaged, right? We did a lot better. And it's also true that when we had these mass promoters, etc., the more that we hired from within the community and had staff who were local doing these activities for us, it worked better. And we also saw that people care about aesthetics. So we see significant differences in mask usage depending on the color of the mask, because we experimented with that as well. So all these details we can provide to anybody who's interested, right? So now just on implementation, and I'll stop here, is that we are working with a couple of state governments. We started with this government in Telangana and in Gujarat, and we have started developing, in partnership with our government counterparts, detailed implementation toolkits, right? Where we talk through, okay, what are the actions that need to be taken across different weeks, and let's have a firm plan on who within the government apparatus can take these actions, right? So we've thought through. I won't go through this. We've thought through, what are the different types of organizations like within a state who can play this role. Sometimes it's government, sometimes it's NGOs, sometimes it's private sector who can come in. So maybe in the Q&A we can talk about that more. And so this is what we are now producing, and this will be ready in the next 24 hours. I think we're working very intensely on it for some of the states we're working with, which is putting together our toolkit in a set of sort of action items, right? So I'm really hoping that as we transition to Mr. Harsha, Mr. Tiwari, and Gagandeep, that we start having a conversation about this detail of the implementation. And I will stop there. Thanks very much for listening.
Thank you, Mushfiq. That's really amazing amount of very practical research that immediately can be translated, and you've taken the additional step of already talking to several states, and so I'm really glad that we are doing this today. Without further ado, I'm going to hand over to Professor Gagandeep Kang to give her thoughts on this. I know you've yourself promoted and argued for much more significant masking, but I'd like very much to hear from you. Professor Kang.
Thank you very much. I thoroughly enjoyed that presentation. It's always great to see work that is done with communities. This kind of reminds me of Steve Luby's studies on hand washing, the brilliant work that he did in Karachi, how it played out in multiple other places. And then when we got to Wash Benefits and Shine, which were around integrating sanitation and hygiene with other interventions, we didn't really see an impact, even though there was high compliance. So here you're trying a variety of different nudges to change behavior. And what isn't really clear to me, and perhaps this is going to come when you have the part 2 of your study, which is going to show us, based on seroprevalence, how much of a change there is across these communities. But you did have calculations about 1 quarter as effective as a lockdown, calculations on costs per life saved, and I just wondered, in all of that, we make a lot of assumptions, but how do we account for keeping these sustained and for heterogeneity across communities? Where you have a community that's much more homogeneous, that behaves in certain ways, it becomes more predictable. I think between Bangladesh and India, we have a lot more heterogeneity. So it would be really good to hear from you about that.
Sure. In the interest of making a conversation, maybe I can, as Gagandeep made these excellent points, let me just highlight.
No, that's great. That'd be great.
So first of all, in one of the first slides, I had Steve's picture up there. So he is the...
Yes, I did notice that. That's why I brought up sanitation and hygiene.
Right, exactly. So Steve was a key member who's leading the Stanford Medical School side and working on sort of the epidemiology, public health of this, right? So the way that the first question about, how do we come up with these costs per life saved numbers, right? So what's going on is that the first stage results, which is how do we get, or what gets people to increase mask wearing, those are ready, which is what I showed you, right? And the second stage result, which is the seroprevalence, right? The stage we're in is that we have collected all the blood spots. We had to rush to do that before Ramzan started. Right? But and then we also have the tests available in country now, right? But the blood specimens and the tests have to meet in one location, and given the nationwide lockdown as well as Ramzan, so that's been a little bit delayed. So we expect to have those results by June. Okay, so what I'm doing right now in the numbers that I showed you is that we take and Gagandeep, I'd be very happy to share the actual paper with you as well. But we take the best estimates from the scientific literature on the effects of masking on transmission, the effects on looking at the fatality rates as a function of transmission. So we take those numbers from the literature, take our numbers on how much masking went up by, combine them in order to create those estimates. Now, of course, as soon as our seroprevalence numbers are ready, then we can just replace the literature estimates to our own numbers. So that's the goal. But given the urgency of the situation, I didn't want to hold back on making the case and writing up this paper, given how urgent it is for us to take action right now. Because as a research team, we've looked at the scientific literature on the second stage. There's many different types of evidence. Some of it is laboratory-based evidence, but some of it is also like, let's look at variation in masking norms around the world, right? Where, in East Asia, there are strong masking norms compared to other countries, and let's look at what happened to transmission rates. So there's many different types of variation people have used, and we feel pretty confident that the weight of the scientific evidence is that the second stage is there. Right?
Well, that's really helpful. And just to add on to the question about heterogeneity across, let's say, Bangladeshi communities versus Indian communities, one of the things that you'd be looking at is sustained behavior change. And what you showed was that across a period of 2 weeks, there was no change in behavior in either intervention or control villages. That's 2 weeks after you left. But is that also within the same households or different households? So when you have 40% masking, when you look at measurement, is that the same households maintaining it over time? Is there intermittent changes in behavior? How are you looking at that?
Great. Okay, these are all really excellent questions. I'm glad we're getting into these details because this is precisely what implementers need to know. Okay? So the first reaction for me is on the 2 weeks versus the 10 weeks, right? So in the first week, the mass distribution happens. So think about the first week as a very intense set of activities that is logistically complicated and possibly expensive because you have to take boxes of mass and distribute it house to house, right? And then from week 3 to week 8, right? That's a period where we are still present, right? But we are doing very light touch work at that time, right? What is that light touch work? It's to return to the village every other Friday, right? To go and talk to the imam again and remind him, oh, you need to make this announcement, right? And do the mass distribution, standing in front of the mosque before the Jummah prayer starts, right? That's one. Second is, I said that we have to go back into the village and intercept people, right? So that is also happening about once a week or twice a week in any given village. So you can have a team who's roaming around the state or roaming around the country and hitting different villages. So those are actually pretty cheap, like low marginal cost activities. So the fact that we get increased mask wearing during that period, right, itself is also policy relevant in that you can increase mask wearing at very low additional cost from week 3 to week 8, right? And what's even more surprising, maybe not surprising, but useful for government, is that week 9, week 10 that we've tracked, right? We take our implementation down to 0, and it still continues to work, right? And that itself, and when we make these estimates of the numbers, the cost saving numbers that we talked about, we basically make the conservative assumption that after like week 8, right, when we leave, the use of masks just goes down to 0. Like we make a very conservative assumption, and even with that conservative assumption, we feel like this is a cost-effective thing to do. And on your question about heterogeneity and differences between India and Bangladesh, absolutely a very, very critical point, right? And for example, just here's a very obvious point. I talk a lot about mosques and imams when we work in Bangladesh. Obviously, that's not where the action is going to be when we work in most places in India, right? We need to think about how do we adapt that same concept, but now use the informal community structure, leadership structure in India, who are the people who has traction, right, and work through them. And I think, Gagandeep, that's why it's going to be important for us as we continue to scale up in various places that we do some light touch monitoring, right, to see whether it's actually working or not as we take it to a new location. And the nice thing about the monitoring here is that it's very, very light touch and very cheap to do, right? So normally when you evaluate projects and programs, as you know, you've done a lot of this, you go do household surveys, which are expensive, right? You have to go sit with the household, write down, spend 2 hours with them, send teams out with tablets, etc. Right? Over here, the monitoring is you have a person standing at a street corner or sitting at a tea shop, just counting heads. How many people are wearing our masks? And what we did to make it easier was we had distinctive colored masks, right? So you could easily also count, how many people are wearing the project masks, right? To see if it works. And so it's actually a cheap thing to continue doing. And then if it turns out that in a particular state, on a particular district, it's not working, then we have the ability to quickly adjust and adapt and try out something else.
This is a very interesting conversation. Gagandeep, any more questions, or should I want to turn to Mr. Tiwari from Punjab. Gagandeep?
I have a ton more questions, but I'll hold them.
Okay, we'll come back and we'll do a second round. So, Mr. Tiwari, who's of course Principal Secretary for Medical Education and Research in the Government of Punjab.
Good evening, Mr. Shah. And thank you, Mr. Mushfiq, for your presentation. Just a few points which were coming to my mind by keeping in view the implementation strategy. It means nobody can have any doubt that we have to create this behavior pattern in the society so that in long run they continue using the mask. First point, when we were talking about type of mask is concerned, see, we are a very big country and vast range of economically weaker sections are also there. Now, when we started implementing wearing of masks here in Punjab, in the beginning itself, there was shortage of masks. So we also distributed masks and we also allowed them an option that they can even use their handkerchief also to cover the face. And immediately, since in the beginning there was some fear psychosis also, I could personally notice while moving from place to place that people were wearing masks at that time. But slowly after lockdown, I found that percentage of people not wearing masks has increased. Now, looking at your experiment which you have done, in this 2-3 things I would like to just point out, because in society behavior changes from place to place. So how you fix a time period, like when you are working in Bangladesh, there may be a 2 week followed by 3 to 8 week touching. then how you will work in various states in India. That is one thing. Second thing is that where we can test this mask efficiency, because if you want to tell people that look here, this particular mask is efficient and the another one is not efficient, how he is going to believe? Now, for example, we are saying that cloth mask has got 37% efficiency. There is a cloth mask with me. Now, this is one cloth mask, this is another cloth mask. And some doctor shown me that if you pour water in a simple cloth mask, it will go down quickly. But here there is another cloth mask where cloth quality is better. It has got some synthetic content also. It holds water. So its efficiency increases and both are washable. So people are, curious about it. Simply, I'm also giving an example because I am visiting various hospitals. This is N95 mask, simple without valve, and this is another mask which contains this valve. Now, doctors are allowed to wear N95 mask with valve because inside the isolation ward, he can exhale his air outside, but he should not inhale within the isolation ward. So I have noticed rich people, very educated people, wearing N95 mask with valve. So you are very right. The perspective is that the person is thinking it is 95% protecting. But if this person who is wearing a N95 mask with valve, and if he is a carrier, then he is infecting everyone. So we have to see time period. Then we have to see what is the economic status of the people. In Punjab, you will find certain type of people who will just wear N95 because it is a symbol of a rich person that he can afford a N95 mask. Okay. Then comes the question of disposal. When at large scale we are distributing these triple layer masks, synthetic masks, how they are being disposed of, because cloth is considered to be biodegradable, but this plastic material or this triple layer mask is not that much biodegradable. So how they are disposing it? I have read one article that you should cut it 3 places. The elastic, you should cut both, then you should cut from the center also. So how we are taking care of the disposal? Then gender issue also. In Bangladesh, you will be noticing maybe that wearing of burqa is necessary for the females. But in India, you will not find that. Maybe, I don't know that in your study, what was the percentage of compliance in ladies and what was the compliance in gents? And what is the age group? Younger children, middle-aged, elderly people. One may say that, those who are going to mosque are very, very religious, law-abiding, God-fearing. The percentage will be more. But on the other way, you can say, somebody who is going to work in an open field, like in Punjab. I have spoken to many of the farmers. They say, I'm working in, my farm. Nobody is around. So why should I wear a mask in a farm? So this is also situations which we are, facing here. And if you go and talk to some athlete, he says, look here, when I am wearing mask and I'm jogging, I can't inhale. So I have noticed here in Chandigarh also, people going to the stadiums for jogging and not wearing. And if I stop them and tell them, they say, no, it is creating problem for me. And then enforcement issue, let me tell you. Punjab police has been enforcing it. Initially, we imposed 500 rupee fine. Then we increased it to 1,000 rupees fine. And let me tell you, increasing fine doesn't improve the behavior. And why? The rich person will be paying and smiling away. Poor says, I can't pay. Do whatever you want to do. So then in that case, poor policeman will say, okay, Baba, you go. I can't do anything. So after that, what we did in Punjab, we ensure that if anybody is not wearing mask, we are going to take him to the testing center and getting his RT-PCR testing done. This has improved the masking behavior, because what has happened, we have covered, such type of testing. Till now, we have crossed 3 lakhs mark, where we have, diverted these people to the testing centers who were not wearing masks. And again, out of that, 2%, 3% were found to be positive. So this news that we are, holding them and taking to the center and getting them tested, and 2% of them were also positive. This has created some sort of, behavior change pattern here also. So obviously your model is very good, but I will say that certain things and certain improvements, if we incorporated in that, maybe in Punjab particularly, I would like to say it can be, improved upon, and a better model can be put here, and we are welcoming you in case any pilot is to be done. Thank you very much.
Thank you, Mr. Tiwari, that you've raised a number of very practical questions. What I think we should do, Mushfiq, is have Dr. Harsha, who himself is a medical doctor, come in and talk to us from the Karnataka perspective, and then perhaps have you respond to these very, very important practical questions. Dr. Harsha, please.
Thank you very much, sir. Thank you for that opportunity. Mushfiq, congratulations for such a wonderful study you guys have done. Really a massive study involving almost 3.5 lakhs for a persistent time. I would like to just share a few insights. When COVID first wave struck, in my previous assignment as a police chief of a city like Mangalore, I was police commissioner of Mangalore city. My first concern was how would I protect my force? Because we have no sort of excuses to make. My guy has to stand on the road and he has to get exposed to the entire population of that city, maybe 10 lakh traversing every day. So my first approach was, we will distribute masks. We will distribute masks. So we took this gold standard that every staff would be given 2 masks to be disposed, because we were not very sure whether it can be washed, reused and all. So we took the same approach of surgical masks to be disposed, 2 masks being given to each staff, and whoever is manning a very sensitive kind of a thing like a traffic barricade wherein he's going into very close proximity, he was given an additional face shield. Wherever possible, wherever they are deployed in COVID centers, hospitals, and where they come in contact with ambulances carrying patients and all, they were given personalized sanitizers and all. In a nutshell, I have seen that in the 6 months that we went through, very long lockdowns, very prolonged exposure, very high infectivity rate. My unit of Mangalore city, the not only the positive cases were very less compared to the rest of the state, but we could very, very proudly sort of connect to the fact that there are 0 fatalities of any of the police staff in Mangalore city for that particular period. Though we have not documented it as scientifically as you guys have done, but I'm telling you the kind of study we could do. So definitely I agree to the findings that your group has done. Definitely surgical masks are worth investing on, and that reinforcement behavior certainly helps. So just quick takeaway for your study group is if it can be enforced through employer, so that he who is bothered about the welfare of the his workforce, be it a corporate company, be it any other kind of a working environment, we can definitely try that employer enforces this with full vigor, and definitely there will be positive kind of a effect. In my current role as principal man communicating the state's communication in the anti-COVID strategies, we did a lot of campaigns on mass media and all, but currently what seems to be working for us right now is I have made all the celebrities, all the religious leaders from all regions repeatedly speak about this and demonstrate that they are wearing all the time, and demonstrate that people who are core influencers are practicing. we not only did it for ads, but we requested and appealed these so-called influencers that even while off camera, when nobody is consciously looking at you, please practice. It seems to be having a very positive effect. But regarding the supply and free supply, I think definitely there is a lot of distance to be covered. So with these inputs, I once time for team. Thank you very much.
Thank you, Dr. Harsha. Mushfiq, do you want to take some of these comments first, and then we'll go around and start answering some of the questions? You have a lot of them in the Q&A box.
Absolutely. Thank you, Mr. Tiwari, Dr. Harsha, for sharing your thoughts. So the most important thing I want to convey to you, is that the goal here isn't to take the model we experimented with in Bangladesh and take it exactly as is and place it in Punjab or Karnataka or anywhere else, right? I think what we need to do is okay, here are some of the conceptual underpinnings of what worked in Bangladesh, right? So just as an example, we learned that while we have a series of things, when jointly done together, it works and it works persistently, it's also kind of fragile, right? In that you take, you do mass promotion or you do mass distribution, but you forget to do the promotion. Turns out people just don't stick with it. You do the promotion one week, but at that time you didn't do the door-to-door distribution. It just doesn't do as much, right? So it's important for us to, given how the scale of the problem in India now, right? And that we really need to get it under control better than we have. We do need to take this kind of a systematic, integrated approach, right? Where what I would suggest, in same as I said in response to Gagandeep, is that there are some ideas we bring on the integrated approach. Plus, you have your ideas on what you've seen works in different parts of the state, right? We kind of put together a model that based on your knowledge and our knowledge, right? And then we try it out, and let's also maybe if necessary, we can just do a little bit of monitoring, light touch monitoring, to see what's working or what's not working, and week to week to week, we can make adjustments as necessary. Right? That's where I'd like us to go towards, and that's the strategy we're taking with the other states or provinces in Pakistan and Bangladesh as well. Right? So, and then some of the details, like the mask type. Right? You correctly pointed out there are very many different types of masks, like N95. Now, I'm not talking about N95s at all, because those are much more expensive. And in our conversations with the various states already, is that given the scale of the issue, like reaching every corner of the state, right? We do need to think about creative, clever ways of doing this cost effectively, right? And the cost of a surgical mask, as long as it's manufactured well, and I know many manufacturers like Magnum in India is able to manufacture high quality masks, right? It's sufficient, right? And then saying, oh, you know what? Another conversation we had is, oh, some doctors are now saying double masking. Okay. My reaction is that, oh, if you can get there, that's great. But what we should be prioritizing is just making sure that we make it easy enough and we stay focused enough such that everybody wears at least one mask at all times, right? And it's clearly the case that, if a farmer is out in the field, it's not that important, right? So we should target our activities and reminders and promotion and interception in high density areas where the risk is higher. Right. So we, I'm completely with you, right? This is not oh, here's a solution, let's dump it on a new place. This is more what, we kind of now understand what is required, right? What type of focus is required. Let's adapt as necessary. You asked about gender. So we saw significant increases in mask usage, both among men and women. Right. So women, it actually started out at a lower, in the control villages lower, and so it was a larger increase, right? But both got to about 45%. We could get 45%, right? It's also the case that if you start out in the villages that start out at lower mask wearing, because there is that heterogeneity to begin with, even before we started working. If you start out at lower, you get larger increases. Right. So another thing I would suggest is let's identify places where we have more of a problem right now. Let's prioritize those locations, those districts first. Right. Okay. Another issue that all of you were saying things that reminded me of, but we didn't explicitly discuss, is the urban, rural, tier 2, tier 3, tier 4, tier 5 town type approaches. Okay, so a lot of what I talked about used a sense of community and social shaming to get mask wearing. We think that, and we did this mostly in rural areas of Bangladesh, so we think those are very important for rural areas. We think that those same mechanisms are relevant for like tier 3, tier 4, tier 3 plus cities, like let's say less than 50,000 population. Okay, but when we start talking about cities where we have different problems, many very different type of population, right? We do need to think about more adaptation, right? And we're happy to be your thought partner to think through that. So right now we're working with the commissioner of Vellore to think about, okay, how does one implement something like this in a city of over 10 million people, which is a very different problem, right? So I think some of the free door-to-door distribution still applies, but we need to think about, okay, what's the sense of community there and how do we do it? So let me just stop there to say that, look, we are trying to create all of the media collateral, the brochures, the videos, all of this. We are trying to make it easily available to governments, right? And the way we are trying to proceed is let's go along the path of least resistance, right? If something kind of fits in already with the government's existing network of, say, ashas around the state, right? Or something like that. Let's try to figure out how do we use those existing networks to get this out to as many locations as possible. And we're very happy to provide all of the technical support, right? To make this easier on you, right? When questions come up about gender, when questions come up about mask type, right? We're happy to think through all of that. And for example, in our the toolkit we provided, we've actually provided details on, oh, here are the contracts and negotiations we had with Magnum in India or with KTEX, which supplied our masks based in Dubai and in Bangladesh. We can provide all of that information.
Thank you, Mushfiq. We have some time, and I was thinking, Gagandeep, if you have any other questions, then we can bring those on. Otherwise, we can turn to some of the Gagandeep.
I think there are a lot of interesting questions in the Q&A box, which might be useful to get to. But just one thing that I really wanted to ask was, if you look at the value of mask wearing, it changes with the interactions that people have with each other. So does it make more sense to invest in change by setting rather than by individuals? So if you said everybody wear a mask when you're interacting with somebody outside your family, versus saying, when someone is walking down the street in an empty village, that's not a high value adoption of behavior to me. So I'd really like to hear your thoughts on that.
Okay, that's a really excellent question. There's definitely trade-offs here, but I'm going to, in spite of the trade-offs and the uncertainty, I'm going to give a very clear answer, right? And you should take it with a grain of salt. But so it turns out before masks, I was working on other things such as sanitation. So we ran very large-scale trials with 75,000 people in Bangladesh on trying to get people to adopt improve sanitation in rural areas. So a lot of this is, and I work on cook stoves, and like my whole life has been spent on like marketing stoves, marketing toilets, marketing new insurance contracts in Tamil Nadu and Andhra Pradesh, etc. Okay, so based on everything I've learned, I would say social norms are going to be really important, right? So Gagandeep, you're absolutely right that if somebody is walking down a village and it's not a particularly risky environment, like say the background infection rates are low, right? People are naturally somewhat distanced because compared to cities, population density is low, right? The fact that, social norms means that my behavior has an effect on everybody else's behavior, right? That I'm more likely to do something. I don't, like, if I'm in a village where everybody else is openly defecating, there's no shame in me doing it, right? But if you put that same person in a different location where it's shameful to defecate in the open, they stop doing it, even if you don't change anything about their budget, about their preferences, right? So as a result, I think it's actually valuable to have a strong social norm emerge that, we all wear masks here, right? That's a socially responsible thing to do, Okay, and the way to get persistent behavior change, because the government is not going to be able to stay there policing this for month after month after month, right? I think the only way to get good persistent behavior change is to change norms, as what's happened in my neighborhood in Connecticut in the US, which is it became abnormal to not wear a mask when exactly a year ago it was very abnormal to wear a mask, right? So then my clear answer is, let's, even though we might be overdoing it in some locations, right? Let's do things such that social norms change, where people find it abnormal to not go out without a mask.
Thank you, Mushfiq. Let's take some questions from the Q&A box. Let me start with a question from Parmita Karim. For those who did not wear a mask after the intervention, did you investigate the reasons? Or did you have a sense of the reasons why they didn't?
Yeah, so I think, okay, so here are some thoughts on why it worked or didn't work in some cases. Right? So a lot of it is like about convenience, right? Yeah, I just forgot it, right? And or people like not taking it seriously, right? So what, the door-to-door distribution, we call it free distribution. So one might interpret that as, oh, this is all about like making masks available, accessible, right? But it turns out the free door-to-door distribution is not just that, right? It's like, I've been hearing since COVID started, I've been hearing 20 different messages on do this, do that, like as Mr. Tiwari was saying, valve, no valve, N95, whatever. Like there's so many different things we keep hearing about, different pharmaceutical interventions, etc. Right? But when we show up in the village and go door to door and say that, look, it's important that everybody does this, right? Whether or not we hand a mask out at that location, that underlining the importance of this, I think, was critical for people, right? And we did see in the heterogeneity across villages, we did see that whenever the community leaders and your friends and neighbors, right, when they were engaged with us, and so they were reinforcing, we had much bigger effects when they were not, right? So this is, and then here's some other things. I said convenience matters, right? So it turns out that like the mask that we have, right, it can easily be hung on the neck as well, right? That's probably not the most hygienic thing to do, right? If I were in a hospital environment, I would say, no, that's not a good characteristic. However, in this case, just the convenience of just having it there so you can easily pull it up, right? So let's say you're walking around, you don't have anybody around you, you pull it down because it's more comfortable, because it's hot outside, right? As soon as you come to a more dense location where you're having closer interactions, you pull it up. Right? That convenience is helpful, even though it might not be the best thing, the perfect thing to do, right? So just doing these simple things to make it easy for people to abide by what you have, I think are really useful, right? Even though it might not be the ideal situation.
I have a question on the implications for urban areas. Your findings suggest that things like putting up a sign outside a household that we are a mask-wearing household didn't seem to work. But the question from Divya Radhakrishnan, would such interventions work better in a urban setting, for example, where a resident welfare association actually takes it upon itself to kind of motivate those households that are doing it to declare themselves to be just like ODF, free, open defecation free villages, same concept?
Yeah, that's a great idea. The reason why we had those signals and stickers is that going into the project, I was quite optimistic that, ODF free and the social signaling, that also helps towards social norm formation. So that's why we tried it, right? And it didn't, unfortunately, work for us. It didn't harm it, but it didn't do anything extra. So yeah, my general answer is that sounds like a great idea, right? And I do think that especially in urban areas, you cannot take the set of results that I am bringing and just like say, okay, yeah, one for one, we can just apply it. I think a lot of innovation and thinking and brainstorming needs to be done in urban areas. So for a particular city, right, let's sit down together, or have you sit down together with other people who are knowledgeable about the city, right? And let's think about, how do we adapt these interventions? I do think I'm on least solid ground when we're having this conversation about urban areas. I do think more needs to be done.
Question from Mohammad Asif Iqbal from SPDC in Pakistan. Was there any resistance from community members for wearing masks? And if so, how did you address that hesitation from the leadership of the community?
We what do we do? We had we did have some. I wouldn't. Resistance is probably not the right word. What we had was something along the lines of like not taking things as seriously. So that was more of the issue that we faced, right? That some leadership was like, this is yet another thing that people are throwing at us, and we're not going to pay too much attention. So it required us to go back, and go back with people who were on our side, so to speak, like convinced, right? Who had some local clout, and go back to the leaders and say, look, this is actually really important, right? And underline, how dangerous COVID is, like what can happen without this. So what do we need to do to work together? So I think it required some sort of persistent engagement, right? And if this is something that it's a question that we'll have to think through. So I'm going to get my colleagues in Bangladesh who actually did the face-to-face work here. We can certainly get their input, and I can engage with you. So please send me an email. My email address is in the chat.
A question from Urvashi Wattal. How did you recruit the people who were doing the in-person reinforcement and the community and religious leaders? What was the pitch that was made, and how were they motivated? Because they clearly played a huge role in the role modeling of this.
Yeah. So on the people who were doing mass promotion type work, so I'm now, just recently on Facebook, if you go to my Facebook page, you'll see my connection to hundreds of these men and women who did this work from across the country. I just wanted to connect with them and see how they felt about this. And people were extremely proud of working on this across the country. So what we ended up doing was there's a kind of like NGO, and even that might be too formal a word for it. It is an NGO, but it's like a set of, generally they're volunteers who all believe in a green Bangladesh. So it's called Green Voice, right? So they normally work on environmental, like they get together around environmental topics. And the person who I had hired about 15 years ago to start the Innovations for Poverty Action office in Bangladesh. So he is part of this network. He's one of the leaders of this network. So as soon as we started thinking about masses, when COVID hit, I called him up and said, okay, we need to do this all around the country. How can we mobilize people quickly, where we also want to limit the amount of travel? We don't want people from cities take the disease and go out into the rural areas, right? And so what we decided was, this network already exists where they have volunteers. Green Voice had volunteers all over the country, right? Let's mobilize them. So then we trained them, right? And we already, it was nice that we already had a network where we had their contact information, right? And these are people who are already, motivated to do something for their society and for their environment, right? And the second important characteristic that we definitely noticed is that when we work with people who were local to the communities, right, that usually worked better, right? And so we selected on that, their local presence. And the second thing we selected on was people who had good interpersonal skills and good communication skills, right? So not like formal leadership, not high education or anything like that, right? But people who are outgoing. That's the main thing that we selected on.
Okay, we have time for just one more question, a couple of minute or two more, and I'll take the last question, which is a very interesting one from Chitra Malolan about adherence fatigue or compliance fatigue. It looks like we're going to have to be wearing masks for quite some time, and that relates to another question about East Asia, where of course mask wearing is intrinsic to public behavior. And so how can we graduate, or if that's the word, to that kind of intrinsic behavior that doesn't need any motivation, that's kind of self-reinforcing?
Yeah, so we've already covered a little bit of this in saying, make it normal, right, as opposed to abnormal. Like make it abnormal to not wear a mask, right? And how does that happen? I think, fatigue is important. That then it becomes really important for us to work through the details at that point of, okay, can we find a mask that is comfortable enough that people don't find it a huge chore to keep it on their face, right? So, for example, there are periods like I think Mr. Tiwari was talking about where there are athletes, right, who think that this is really inconvenient, right? And I happen to do a lot of outdoor activity as well, right? And over time, I have gotten used to it. Right? So let's try and figure out, okay, what are the materials that are comfortable enough such that people keep it on, that everybody will do it consistently. And once you're doing it consistently, and there's just light touch reinforcement from the government, look, this is important to do because people have to protect each other. We do see like social norms changing. Like there are other things for which that I would say much bigger changes in behavior that we've managed to change social norms. Like open defecation is one such thing, right? Which requires a much bigger investment than a mask, right? It's something that costs 100 times more or more. So that's so I think it's feasible. And one final thing, Mr. Tiwari raised some important points about disposal, right? So I think the environmental implications of large-scale mass distribution, we should keep it in our minds, and we should have a good plan for it, right? But at this moment, given the scale of the health crisis, right, I would say if you were to do sort of a careful, sophisticated economic cost-benefit analysis, right, thinking about what is it that we need to do in order to protect us against the virus, right, that's orders of magnitude more important than the disposal of things that are not very bulky, right? I think it's important, but right now is not the right time to prioritize that thinking. But if possible, we should have a good plan for it.
Okay, with that, let me bring this really interesting but also extremely important webinar to a close. I want to thank Professor Mushfiq Mobarak and his entire team at Stanford and at IPA and at Yale for the tremendous work that they've done. This is what really research in moments of crisis has to rise up to, how one can translate research into real action on the ground. And I'm grateful to you, Mushfiq, for this and for your entire team. To Professor Gagandeep Kang for raising some really interesting questions. We are really indebted to you for the leadership you're showing, Professor Kang, on the epidemiological front. We kind of wait for every word from you as to where we are going and what we should be doing. I also want to thank Mr. Tiwari for joining in with some very practical questions about how we must implement this, and then Dr. Harsha for his experience from Mangalore and of course the work that he's currently doing in Karnataka. With that, let me thank the entire team at NCAER as well who has made this possible, and we want to wish you all not just a good evening and a good morning, but also want to make sure that you stay safe. Please do take all the precautions you can. Wear a mask. Thank you very much. Good evening and